Thank you very much, Rufino. You've heard now from Vas and Rufino about the importance of anti-VEGF monotherapy, and we can maybe hopefully discuss a little bit about the different agents and their varying responses. I would like to move on now to an alternative approach, which is the addition of photodynamic therapy, known as combination therapy, and the evidence that supports it. These are my financial disclosures. We are fortunate now that we have quite a body of evidence, level 1 evidence, supporting various treatment strategies for polypoidal. You've seen monotherapy with Planet, with HAWK, with TENAYA and Lucerne. A combination therapy largely came about through the work of Everest 1 and Everest 2, which I will spend a little bit of time on. Why do we need PDT in the first place? Very often, we do that only when anti-VEGF is not working, or when anti-VEGF alone is not enough. And the fact remains that for polypoidal, different from choroidal neovascularization and typical AMD, up to 50% are anti-VEGF non-responders. And you can keep injecting as long as you want, or as often as you need, but you may not get a full response. Frequent injections, therefore, are required. High recurrence rates when you stop the therapy, right? Because you have only controlled disease activity, but you have not necessarily altered disease. The polypoidal lesions persist in up to 2/3 of cases, depending on which anti-VEGF agent you use. But we are beginning to see better and better responses in terms of polypoidal closure. And what happens with these persistent polyps is a problem. We call them the ticking time bombs, where if you leave these polyps open, will they finally come back and bite you with massive hemorrhage? There's various studies showing that PCV is an important cause of early poor response to treatment. By early, we mean within the first 3 injections. So very early on in treatment of exudative AMD, within 3 injections, you're not getting any response at all. And if you were to do ICG on these patients, up to 56% of them will have polypoidal lesions. So this is really one of the red flags that we are recommending. If you're treating with anti-VEGF, watch them after the first initial loading dose. And if you're not getting a response in terms of resolution of fluid, think about underlying polypoidal. You can then go back to your OCT, look for some of the features that we talked about that might give you a suspicion of underlying PCV. But the reality is there will be a significant proportion of non-responders that turn out to be polypoidal. The problem is when you start with anti-VEGF therapy, only about 1/3 of patients with aflibercept treatment had complete polyp regression at 2 years. As I said, the evidence is changing with the newer anti-VEGF agents. And if we leave these polyps alone, you don't see an effect in the first 1-2 years. Up to 9 years later, you have a much higher risk of things like massive hemorrhage. In this Korean series, 40% with persistent polyps at 9 years. Everest was really started as part of the entire SUMMIT program, not just for polypoidal, but really for choroidal neovascularization, trying to determine if combined therapy was useful. We know that that's not been found to be so for choroidal neovascularization. But this is Everest looking at just purely polypoidal choroidal therapy. And the rationale here is that PDT is really good at closing polyps down because of its unique thrombotic effects, vascular thrombosis. The anti-VEGF is needed to resolve fluid, to control the disease activity from choroidal neovascularization or branching vascular network. And the more important thing I feel is that the anti-VEGF actually balances out some of the negative effects of PDT. We know that PDT can increase exudation, transudation. It can also upregulate VEGF. So that's what we do not want from PDT. Everest 1 was a pilot trial, really first randomized trial. We were looking at polyp closure. And so the 3 arms here reflect that. Combination, PDT alone, and ranibizumab alone. And essentially what it showed was when you have PDT, either on its own or in combination with ranibizumab, we have a very high chance of closing polyps down. This is at month 6, 77% with combination. And with ranibizumab alone, it was less than 30%, which is consistent with what we recognize. Because of that, we moved on to a larger study, which is Everest 2. This time, we dropped PDT monotherapy. Now we don't talk about PDT monotherapy anymore. Combination versus ranibizumab alone. And this was our treatment schedule, 3 initial loading doses with PDT and subsequently PRN over 12 months. So at month 12, the visual acuity results were beneficial. So interestingly, the combination therapy arm did better than the monotherapy, and this was maintained into the second year, 9.6 letters versus 5.5. Mean change in the central subfield thickness reflexes, you see very, very rapid reduction in fluid, and very good stability and maintenance of a dry retina. Fluid-free retina, this is really our goal in AMD. 70% of patients with combination therapy achieve this versus half of that in ranibizumab alone. And this was the real kicker. Complete polyp regression, much better with combination. So in a way, it validated our own clinical experience and also the suggestions from Everest-1. This was post-hoc analysis, but what was interesting is stability of disease. We all have problems with load of clinics, with multiple injections required. Here, with combination therapy, the mean time to reoccurrence of disease was 270 days, 9 months. So after your initial 3 loading doses, one PDT, 3 injections, and maybe 1 or 2 more injections, you have about a 9-month period of disease-free activity. This is really quite unprecedented. In terms of treatment burden, therefore, it's highly reflected. You see that the mean number of injections in the first year was 5.2 with a median of 4. 4 injections means 3 loading doses with 1 additional ranibizumab. So disease burden is greatly reduced. If you compare them across the board with monotherapy trials, of course, you'll find that there's a significant reduction in injections, which we're all trying to do. So regardless of ethnicity, of geographical location, PCV is responsible for a significant proportion of anti-VEGF non-response. And then this response can be detected very early in the course, within 3 to 4 injections. Combination therapy has advantages. We believe that with combination, you have a higher rate of complete polyp regression. You're not just inactivating disease. We have higher rates of complete resolution, so having a fluid-free retina is what we want. Longer treatment-free intervals with combination, and a reduced injection burden. So to round all this up, and you've heard now the evidence from anti-VEGF monotherapy, I presented some combination therapy. This is the current thinking or consensus among most PCV experts. PCV treatment, and as we move towards an era without ICG, we will be able to gain more experience, more data with this. This is work from Jemmy and others, where if we have suspected PCV, you heard of the 3 criteria, the major criteria on the OCT that will give you a relatively high rate of confidence of diagnosis. Now, let's say you have made a diagnosis of PCV with or without ICG. Generally, we would recommend starting with anti-VEGF monotherapy. Now we've got choice. We've got so many anti-VEGF therapy to choose from, and it's up to you to decide. We can discuss later pros and cons of each. After 3 injections, if you got a good response, continue with anti-VEGF monotherapy. My suggestion is use a treat and extend, which has been validated by Atlantic. But if you're not getting complete resolution, no improvement at all after 3 injections, do an ICG. Because you will need that ICG to be definitively sure that you are dealing with underlying polypoidal. And if you're going to add PDT, you will need the ICG anyway. We will want to cover the branching vascular network as well as the active polyps in our primary treatment. I know that in many parts of the world, PDT is a problem because of the lack of availability of Visudyne. I think if that continues, we may have to really look at other modalities like micropulse. But at the moment, the evidence is lacking for anything other than PDT with anti-VEGF. If it's not PCV, of course, that's a different story. So when we compare combination and monotherapy, there are pros and cons of each. As I mentioned, the benefits of combination are higher rates of polyp closure, lower recurrence rate, longer disease-free intervals, fewer injections. On the other hand, monotherapy has excellent vision outcome. It controls disease. You don't have to use ICG if you're going to treat purely with anti-VEGF monotherapy. And of course, you avoid the risk of complications. So when do I use combination? Sometimes from the start, right? These are the situations where vision is poor. When the vision is good, there is really no need to rush into combination therapy. But when the vision is poor, 6/15 or worse, for example, in Japan, I think combination therapy may be more useful in the long run. Larger polyps, pulsatile polyps, you heard that from Giovanni earlier. Pulsatile polyps are usually more aggressive in terms of hemorrhage and more difficult to close. Large hemorrhagic pigment epithelial detachments, these are also very challenging to treat. So I have a greater tendency to use combination. And of course, those not responding to anti-VEGF. Equally important, we need to know when to avoid photodynamic therapy. And we know of all the problems with full fluence, and some people have moved towards reduced fluence or half dose. Good initial vision, I would say you don't need to start with combination. Those with thin choroids and pre-existing RPE atrophy, be very careful of PDT. That includes high myopes, by the way. Activity that's not coming from polyps. So we have to be able to differentiate that the disease activity, the fluid, is not coming from polyps. Sometimes it's only from the branching vascular network. And of course, when there's a lot of hemorrhage, it's very difficult to image really the presence of polyps. So for recurrent PCV, so that was primary treatment. For recurrences, the treatment strategy is slightly different. Number one, we have to determine where the activity is coming from. Very often it's not from polyps anymore. It can be from the branching vascular network. Our key goal is to reduce the risk of RPE atrophy. So when we apply PDT, we do not want to treat the entire lesion anymore. Selectively apply PDT only to polyps, not to the branching vascular network. Try to avoid multiple repeat sessions of full fluence PDT. Repeat PDT in patients with thin choroids, pre-existing RPE atrophy should be avoided. I use reduced fluence usually for repeat PDTs. Keep the spot size as small as possible. And a few of us also add steroid as a form of triple therapy. This is an example where previously treated with combination, he does very well. After 1 year, he presents with activity again, and you will see that the activity is only from this polyp, and therefore the PDT is only applied there. You do not need to apply across the whole lesion. The second case shows recurrent activity, but without polyps. So the recurrences here do not need PDT. BVNs generally do not respond. They behave more like type 1 occult CNV. And so these patients only require anti-VEGF therapy, very often a treat and extend. So thank you, and I hope I've summarized the treatment.
Thank you, Adrian. And now I call Jamie. Jamie, please.